Alrighty, so welcome back from the break. I hope everyone's got a bit of movement and they're energized. So for those of you who know me, hello. For those of you who don't know me, hello. Hello to everyone. And welcome to Pasi MC. So people who've been attending sessions with me know what I do. For those of you who don't know what I do, well, Pass AMC was something that was started by myself. It's, I can say it's like a baby of my own failures. So basically it's the hard time, the struggles that I had to do, I had to go through when I came in this AMC journey. And the way I went over it and the way I tackled this whole preparation and in order to help other people and to minimize their pain and suffering is the main reason why I created Pass AMC. Okay, so I really hope that whatever we do with the sessions is highly helpful and you can learn from our mistakes. So people who would be teaching on this platform and you don't have to go through them, like the mistakes that we've made. And the goal is to make you better than us. So if I know 8 out of 10, I'm really hoping that I can be able to give you 9 out of 10, a step more than what I know. So that's the main goal here. So today what I'm going to talk about is pain, approach to pain. So pain is a very, very common symptom that you will see in AMC in the cases. Yeah. So for example, you can have a person with like headache, that's a pain, right? How do you manage pain? How do you manage that as a symptom? You can have chest pain, abdominal pain, like there's so many pains. So the approach to pain, I thought was really important because not only for AMC, but even when you start working, it'll be very important to know how do you manage this particular problem. Yeah. So what is pain? So the International Association for the Study of Pain defines it as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Okay. I hope everyone can see the screen nice and clear. So pain is always a personal experience. So my experience of pain may not be the same as somebody else, right? So it depends, and it depends based on different reasons. So it could be like a biological reason, a psychological reason, a social factor that's involved. So it varies. We need to respect patients who come in with pain, and the goal is to not be judgmental. Yeah, although like it will happen when you start working, you'll see a person, you say, oh, how bad is your pain? And they'll be like, oh, it's really severe, I'm dying. But they don't look that bad. Okay, what do? You cannot make fun of them or laugh or whatever. Like you need to respect them because pain is always a personal experience. Okay, you need to acknowledge that, say, okay, I'm really sorry that this has happened, and then keep going, but do not ignore the fact that they're saying it's 9 out of 10. Okay. Okay, so it's an individual experience and it should be respected. Yeah. All right, so after many years of medicine, like how humans evolved, medicine has also evolved, but pain still does not have a clear definition. Okay, so it remains person to person. So what I've done is, like I said earlier, AMC has many scenarios. Pretty much, I can say 80% of what you will do in AMC will involve pain. Okay, not your personal pain, but the cases will have pain. So I'm telling you, like more than 80%, like every sort of scenario you read will have some pain: headache, shoulder pain, back pain, abdominal pain, leg pain. Yeah. So it's important that we master pain and the approach. Okay. So for example, a few things like, how do you define pain? So is it something that's acute, or chronic or recurrent. So these are the terms we use in the hospital, in the system. So a lot of what we do is communication at work, and AMC wants to see if you're good at communication. So they've developed a station called ISBAR, yeah, where you need to give a handover to another colleague or a nurse or a doctor. Like, so when you talk about the first sentence, like, good morning, Jenny, my name's Amrit, one of the doctors in the emergency department. I'm calling about a 63-year-old female who presents with recurrent back pain. You see, like the sentence, the words that we use make a big difference. So define the pain. Is it acute onset, chronic, or recurrent? Yeah. So this will give you like a good starting. Okay. So we all know the mnemonic that we use for pain or for inquiring deeply into the history of presenting complaint. So this can be your SOCRATES, your LOTRADIO, SORTSARA. It's LOTRADIO. Okay. Right. So how do we talk about this in practice? Like, how do we go about it? First of all, please, if you do not know about this mnemonic, welcome. Now is the time. Make yourself familiar. Memorize it, store it in your brain. This is like the most important thing you need to know. The most important mnemonic in AMC, okay? In your life, actually, as a doctor. So first thing, site. So site is basically the location. So where is it that you're having pain? Right? So if somebody came in with pain and I just give them Panadol, I give them like oxycodone, and I've not asked about pain, I'm not a good doctor. Like, that's a bad practice. So first thing, I want to know the location. Where is it? I personally like using the finger. So I'll say, John, can you please point to the location of the pain with one finger, with your index finger. So you can do that in your exam. Can you point with your index finger where it hurts? Okay, so if I point specifically, oh, doctor, it hurts here, or it hurts here, rather than my hand is a big space, okay? So one finger can give me the exact location, okay? So locate the pain, right? Then you wanna know, is it localized or is it diffuse, right? So ask, like, John, does it hurt just where you're touching or also in the surrounding areas? Right? So always try to understand more. Then you want to know the onset. So find out whether the symptom came on like rapidly, gradually, or instantaneously. So I personally like use LOTRADIO or SORTSARA or SOCRATES for everything, not just pain, but everything. Any patient that comes in, this is my frame that I use to take history. So for example, somebody came with PV bleeding. So I want to know, when did it start? So onset, okay? Like location, I know it's PV bleeding. I know where it's coming from, but like, when did it start? So onset. So find out if it's rapid, gradual, or instantaneously, okay? Again, when you do ISBAR stations and when you start working as a doctor, you will use these words to communicate. You will say that it is sudden onset, okay? Or is it diffuse? Like, sorry, it's a gradual onset, sudden onset. These words make a big difference, guys, because somebody who, for example, came with chest pain and the chest pain started 4 days ago, my management to that patient will be so different in comparison to somebody who came with chest pain that started 10 minutes ago. Does it make sense? So the way I approach the patient will totally change. So somebody who's like unable to see, let's say visual loss, right? Or even headache, sudden onset that happened like now, like 10 minutes or an hour ago, as compared to something that's been ongoing for days or weeks, it's going to be different. Your differential diagnosis in your brain will be different, right? Because at the end of the day, the reason we're asking these questions is to formulate a differential diagnosis in our brain, isn't it? So, okay, so we've asked about the onset. So sudden, gradual, instantaneous. So ask about that. Then you want to know about a little bit about the character. So ask about the character. So I usually ask the patient, like, can you please describe it for me? For example, if we're talking about pain, is it like sharp? Is it dull? Is it stabbing? Is it like burning? Is it cramp-like? So if you give the patient the words, you'll waste time. Okay, because you don't have much time in this exam. So say, John, can you please describe this in your own words? Let them do the talking. Okay. If you're not clear, then you can ask follow-up questions like, is it like a stab? Is it like a burning? Is it like a cramp? So then you can follow up, clarify, but always try to ask open-ended questions. Yeah. Awesome. If you have any questions, everyone, feel free to interrupt, ask. I want to make sure we're clear on this mnemonic, because it will save your life in so many ways. Yeah. Okay. So we've done the character. Now we come into the radiation. Okay. So understanding of radiation. So like I said, when you point with one finger, it's localized, like to that location. Like, for example, I'm pointing now to my left shoulder. So I want to know, is it moving anywhere? So radiation is basically, is the pain traveling from point A to point B? Right? So you want to know. So John, does it move anywhere? Yeah. You can make your words simple, or you can even use like, does it radiate anywhere? Whatever, doesn't matter. So it will give you some more understanding on the differential if the pain is radiating, right? Next, alleviating factors. So ask if there's anything that makes their pain better. Okay, so for example, sometimes position can make a pain better, like a person who has pericarditis, like so it depends on their pain and the position they're in, right? Somebody who has back pain, for example, lifting something heavy will be like, it hurts, right? So you want to know what makes the pain come on and what makes it go off. Okay, so alleviating factors, aggravating factors. So ask about them. Is it like is it a position that makes it better? Is it a medication that makes it better? Right? So is it like not moving at all that's making it better? So ask these things. Okay. Timing. So timing is basically, when did this symptom first begin? So try to accurately understand, like, when did the patient notice that something is not right? Ask about this. Okay, this is the timing. Exacerbating factors, like I just mentioned, so you can combine them, alleviating and exacerbating. So what makes it better, what makes it worse? And then the severity. So severity is really important in this whole pain scenario. So severity is subjective, okay? The best way to assess it is by, I'll show you some scales. It can be like mild to severe. How will you choose what way to ask the severity? Okay, so for example, let's go to our next slide. So the severity can be used between, like, from 0 to 10, 0 being the least, 10 being the most. Where do you think you are, John? You can ask that. You can use visual analogs. You can use the faces. You can use the Flack scale. So we have a couple of things which are available to assess the severity. Pain severity means pain intensity, okay? Simple things. So for example, 0 to 10. 0 means no pain, 10 means severe pain. Where are you? You can say that like a question like that, okay? So we have different scales, guys. So we've got like a numeric rating scale, 0 to 10, versus the Wong-Baker Faces Pain Scale. So the Wong-Baker Faces Pain Scale is developed for younger people, like children, and you can show them like, hey Timmy, on a scale of 1 to 10, look at this. What face do you think you are? So let them pick which face they think they are, okay? Because if you ask a 8-year-old, like on 1 to 10, where are you? They might not they might not give you the right answer. But if you go over with the face, like the different faces, you're like, hey, Timmy, look, this is the face that's happy. Are you happy? No. Okay, let's look at the other one. Let's look at the other one. Like, so like that. Okay. So you need to be a bit playful with pediatrics. And this Wong-Baker face scale is printed on the observation notes in the hospital. It's part of the notes. So it's, you just have to show them, and then they'll see it. In AMC, you can tell the examiner, I would like to show the patient the Wong-Baker face scale. Boom, you've earned a point. Yeah. Somebody sitting in India might not know what is Wong-Baker face scale. Now you know, so you have 1 point ahead of them, right? So demonstrate your knowledge where possible. Okay? When you're interacting with the examiner, demonstrate as much as you can. You have the Abbey pain scale. So these are like measurement of pain in people who cannot verbalize. You don't need to know about this. You have the Flack pain scale. So I'll go over the different ones. So there's a Lego pain assessment scale, similar thing. So it's nothing but little Legos. Some hospitals have that, but mostly they use the Wong one. Okay. The Flack pain scale. So Flack is a assessment of behavioral score. So FLACC. So face, legs, activity, cry, consolability. So it's a score out of 10. So 0 means relaxed and comfortable. 1 to 3 means they're in mild pain. 4 to 6 means they're in moderate pain. 7 to 10 means they're in severe pain. So in children, we cannot, like little kiddies who can't talk, we can't rely on the Wong scale. We can't rely on the parent. Like, hey, John, how much pain do you think your kid is in? We cannot rely on their information. So we need to assess. Okay, so you can use this Flack pain scale about the behavior. How is the behavior of the person? Okay, are we clear? Apart from this, the other thing, so you'll have sometimes patients who are autistic, they cannot verbalize pain. Okay, you can have people who are really, really sick, like the elderly, they cannot verbalize much. Or you can have some kids also who are really strong, they have a good pain threshold, or they come from cultures where saying that they are in pain is a bad thing. So how do you know that somebody is in pain? The physiological system in the body does not lie. Okay, if somebody's heart rate's going boom, 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 you know, if their breathing is going up like they're having tachypnea, means something is not right. They're having pain. Okay, something is definitely not right. If the blood pressure is not in the normal ranges, if the oxygen saturation is not normal, it means something is going on. So we always look at the physiological aspect as well. And then we can tell that, okay, this person is in pain. There's something going on for sure. Okay. I'll give you a little story. So I had a kid, 8-year-old. I kept asking the kiddie, like, are you in pain? Are you in pain? Nothing. Like, he didn't want to say that he's in pain. I don't know why. Like, he didn't want to. His respiratory rate was off the hook. Like, he was like super tachypnic. No respiratory condition like that could explain why he's tachypnic. Okay, heart rate tachycardic, like I cannot explain why he's tachycardic, but he does not want to say he's in pain, right? And then obviously, like, we find other ways to understand that, okay, this kid is in pain. So it's always like you take history and then you rely on physiological findings. Okay, so I will explain this like physiological aspect later when we discuss a case. I'll show you the examples. But yeah, I hope you guys can keep that in mind as well. When you read the case outside for 2 minutes in AMC, have a look at the vitals. They usually give you the obs. Okay, cool. Okay, let's move on. Now, let's say a patient is saying, I'm 8 out of 10 in pain, but they're happy, they're chatting on the phone, they're doing Instagram, Facebook, and the nurse passes by, she sees like, oh, how can he be 8 out of 10, doctor? Like, I think he's lying. So what do you do? The answer is, like I said, pain is something that is a personal experience. You need to respect it. Don't be judgmental. Okay, you need to address that. It's 8 out of 10 means it's 8 out of 10. So think about the underlying pathology, like what is happening, what is the nature of the pain, what have I done as a doctor to manage the pain. If somebody is saying 8 out of 10 and they're on the phone and I've not even given them Panadol, that's not good. Okay, because some people can express, some people cannot express. So please do not judge people just by what they're doing. Do your job. Yeah. Okay, great. All right. So, okay, before we go into the options, let's just discuss a little bit. So what do you think? What is like somebody coming with pain? Like, let's say, let's divide it into mild, moderate, and severe. Okay. So if it's a mild pain, what do we do? What's your approach to mild pain?
We'll give Panadol.
Okay, sure. What else?
Or we can ask them if they're comfortable enough to, you know, to sit, or do they want some painkiller? Like, you have to ask them their opinion whether they need something.
Yeah, definitely. Yes, yes. What else? So what would be your approach? Let's say 12-year-old child came with headache, which is 4 out of 10. What is your approach?
I think we'll start with Panadol.
Okay.
First, ask them if they've taken any medication before.
Okay, good. That's good. Yeah. What else?
Ask for allergies before anything else.
We'll look for vitals. We'll check the vitals first.
Yeah.
We'll ask for severity first, like the scale which you've just shown for 12. We might ask which phase are they, just to see the severity.
Yeah.
Just to get an idea, and then we will manage accordingly.
Okay, fair enough. Let's say now you have, what's that? Okay. Let's say you have a 4-year-old who is not weight bearing. Okay. So obviously, like, they're having pain when they weight bear. What do you think? Like, how would you approach this kid, a 4-year-old not weight bearing? Like, pain wise, how would you, like, let's say you've done the SORTSARA or LOTRADIO, SOCRATES, whatever, and now it's your assessment of this person is, let's say they're 3 out of 10 at rest. How do you manage them? Three out of 10, non-weight bearing, 4-year-old child.
Still give them some non-steroidal anti-inflammatory.
Okay. Is there anything else you could do?
We could offer the patient to lie down and not bear more weight. As for allergies, show the pain scale, comfort the mom.
Okay, so Samira, very, very good. I like the fact that you said comfort the mom, okay? In pediatrics, reassuring is very important. So the parent is usually quite anxious, so reassurance is important. So please do that. So we've done some brainstorming, so let's go over the options, okay? So pain relief options. Let's say it's mild acute pain. So the first thing we do is non-pharmacological approach plus paracetamol. This is your basic approach to a mild acute pain. So my question to you when I was asking you follow-up information, like questions, was the non-pharmacological approach. So Samira said reassuring the mom, which was great. I love it. So what else can we do in non-pharmacological approach? Any options?
Positioning the patient and hydration with ice cubes.
Icy pole, yeah.
Icy poles, yeah.
What else?
Okay, a cold pack if they want to put a cold pack somewhere, if they hurt somewhere.
So like the price management.
Very good, Umara. Yeah, that's a good way. Yeah.
So rest elevation and heat or cold
Okay.
compression, depending on that.
So always keep in mind, do not jump on medicines. You are a doctor, you have the authority to prescribe, but that does not mean you need to jump and do it and give medicines. No. First, understand what is the problem. Okay, it's problem solving basically. So doctors are more like engineers. They need to problem solve. A good doctor will be a very good problem solver. Okay, so first understand the problem, see where it's coming from, what type of thing it is. Then when it comes to solving the problem, go step by step. Okay, so pain relief is also a step ladder. So we go step 1, 2, 3, 4, like that. And to understand which step you're starting on, is it mild, is it moderate, is it severe, the approach will help you to guide where to go. Okay, now talking about non-pharmacological approach. So simple things, very simple things like reassurance. Yeah, people take what doctors say very seriously. So if a doctor says, oh my God, sorry, John, it's bad, the patient will start having tachycardia, like, oh, I'm dying. But if you reassure them, like, hey, buddy, nothing's wrong with you, you're doing really well. Or, you know, like giving them some positive words, like, hey, John, look, your health is very important and we're going to look after you. Okay, don't worry about it. So it makes a big difference, right? It will change their approach to the way they look at their problem. So first thing, reassure. Okay. Second thing, rest. So please rest, lie down or sit up, rest in the position of comfort. Okay. Next thing you can do is you can ice the place that's paining, or you can heat pack it, depending on what kind of condition it is. Of course, like if somebody is coming with chest pain, you're not going to give them an ice pack to put on the chest. Okay, but you can reassure them. Okay, if it's a musculoskeletal pain, you can give them an ice pack or a heat pack, whatever, like it makes sense. Got it? Okay, then if it's a child, the pediatric with pain, how do you manage those? So how do you reassure? Hang on, I just need to mute a few people. Okay, sorry. All right. So if it's a pediatrics, like a pediatrics group with pain, so my approach would be, again, reassure the parent. Tell them that, Jenny, thank you so much for bringing Timmy into hospital. You're such a good mom. Now look, kiddies in pain, what we're going to do is make sure they're comfortable. So I'm going to try and get some, so what can you do? Options. Number 1, atmosphere, right? Make sure the temperature is good. Make sure like it's not too cold or not too hot. Make sure it's quiet. So the atmosphere is quiet. For example, like somebody who came with a little kid who's crying, unsettled, I will not put them in an area which is noisy. I'll put them in a quiet space. Okay, so quiet atmosphere. I'll tell the parent to be there. Do not leave the kid alone. So parental eye contact. Very important for kids. Swaddling the kid, okay? Very important. Tell the mom, why don't you carry Johnny and pat Johnny or play with Johnny, like swaddle the kid. Music can be very therapeutic as well. So some gentle music, some distraction techniques. So we have some iPads in the hospital. We can give it to the kids. They can play some game, video, whatever. So some form of distraction, or also toys. You can give them like one time, like use and throw toys to distract them. You can hug them. You can give them familiar toys. Like some kids have their particular toys, which they cannot live without. So familiarity is good for little kids. And storytelling is also another approach to calm down kids. So oftentimes in ED, we'll see parents like they'll sit with the child and they'll just talk about some story or just have a conversation with the kid and try to calm them down. So these are all non-pharmacological approaches to pain relief. Make sense? So when you do a case in AMC, please talk about non-pharmacological approach first, right? Again, you'll get 1 point more than the other people. Bingo. Okay. What do you do next? you can give paracetamol, okay? Paracetamol, this is adult dose. Children's different, it's based on the weight. So paracetamol, for example, 1 gram orally 4 times a day, that's the max dose you could do, okay? Now, moving on, let's say it is moderate pain. What do we do? So again, once again, non-pharmacological approach, right? Plus paracetamol, plus NSAIDs. So NSAIDs can be things like ibuprofen, diclofenac, naproxen. And when you prescribe NSAIDs, you need to look at the potential benefit and the harm. Okay, you don't just give NSAIDs. Can anyone tell me, like, what are the side effects? Like, why are we being so careful with NSAIDs?
Because if we are having the kid is having a viral infection and we're giving aspirin, it can cause Rice syndrome.
Okay, what else? Good, what else?
GI complications?
Yeah, excellent, good. Hey guys, you know, when people answer, this is so silly. When people answer a question, on your screen, there's this thing, the icon that says clap. You can do that for them. They'll feel good. So you know, have fun. Don't get too serious. Enjoy the process and motivate others to talk. So let's give people claps when they answer, or a thumbs up. Okay, so yes, GI complications, good. So whenever we prescribe NSAIDs, I particularly am very careful in elderly. I try not to prescribe NSAIDs to elderly because usually they have heart problems, they have kidney problems, they have ulcers. So these are some of the main things we are worried about. So for example, in the heart, it can cause increase in blood pressure, fluid retention, stroke, heart attack, although it's very rare, but still, like, I try not to prescribe it unless it obviously, like, the benefit is way more than, you know, the risk. So in the GI tract, you can have things like upper GI pain. It can cause gastritis, erosion, peptic ulcers. So again, like, you know, you need to have a look at their history. If somebody has already ulcers, or they have GORD, or they have like a low hemoglobin, I would not give it. Then kidney, again, like kidney. So if the UECs are back and they have a poor kidney function, I will not give it. Okay. So elderly people, be very careful with NSAIDs. Young ones, it's okay. Of course, unless they're allergic, then you will not do it. But otherwise, yeah, it's fine. So you can go with NSAIDs. NSAIDs can come in oral or IV, IM, like that. Okay, so what else can you do in moderate acute pain? So you could do the NSAIDs, you could do oral opioids. So oral opioids are medications like codeine, tramadol, oxycodone. There's some very interesting formulations. So you can have paracetamol with codeine. Yeah, you can have NSAID, like ibuprofen with codeine. So this gives one more kick to the pain. Like, it's a next step. Let's say you've given paracetamol, you've given ibuprofen, but still they're not feeling any better. You could do the next line, like Panadine Forte, so which is a combination drug. Or you could also just give them oral opioids. Tramadol is a good one. Oxycodone is a very common drug that we use. Okay, so the main form of medications that we use in pain relief are the NSAIDs, paracetamol, codeine. These are the basic ones. Okay, opioids. Opioids are things like codeine, morphine. We go for these. Tramadol. Then another class of drugs are the anti-epileptic drugs, pregabalin, gabapentin, things like that, and antidepressants. So the tricyclic antidepressants, amitriptyline, duloxetine, these are another kind of drugs that we can use. Okay, so again, like understanding the kind of pain a person is having. So for example, if someone has vesicular rash, which is painful on the chest, okay, on one dermatome, what would be your approach? What will you give them?
Gabapentin sort of medication.
Yeah, exactly. So this is like a neuropathic pain, right? It's herpes. So it's like shingles, post-herpetic neuralgia, whatever. So will you give them morphine? No, you need to give them something that's for that neuropathic pain. So gabapentin, pregabalin, these are good, okay? So pick and choose depending on what kind of pain you're trying to treat. I'm going to touch base on that as well in a bit. Another thing you want to keep in mind is the root of analgesia. So what are you doing? So although let's say it's moderate pain, like I have pain, let's say my pain is, I have abdominal pain, but it is 4 out of 10 and I'm vomiting as well. Like I feel nauseated, I've vomited twice. What would you do? Would you give me oral medication?
No, IV?
No.
So of course, like depending on what's underlying, oral route is always the first one we prefer. But if it's not acceptable, think about other things, subcutaneous, IV, IM, you can do different things, intranasal, depending on how severe it is, okay? All right. Let's talk about severe pain now, severe acute pain. So what do we do? So again, if somebody came like 10 out of 10 pain, I will not give them oral, right? My route of administration will change. Make sense? So the route will depend on the severity of the pain and how quickly I need to give them analgesia. Okay, so of course, whenever we do severe pain relief options, we want to make sure we have the facility available, because the drugs in this category can give serious complications. So we make sure that there is a resuscitation facility. We have senior doctors, we have nurses, they're monitored. So that's when we give them. You don't give IV morphine and leave the patient and go see another patient. You need to stand there and keep an eye on them, see the breathing, see the vitals. So just a basic approach, okay? So these are medications which are mostly IV. Examples of conditions which are severe are like your chest pain, like myocardial infarction, ACS, renal colic, right? Trauma. So these are all severe. Now, if somebody came with trauma, let's say after a motor vehicle accident, are you gonna sit there and find an IV line while they're 10 out of 10 screaming in pain? No. You could do subcutaneous, okay? You could do subcutaneous morphine. You could do intranasal fentanyl. These are options. Our goal is to get them comfortable as soon as possible. Whenever people come with pain, as physicians, treating doctors, we need to make sure we can address the pain and fix it immediately. Do not take history, do not waste time, and not address pain. So address your pain, then take your history. Got it? So I'm going to talk a little bit about severe pain. So severe pain, look, we have a few options available. So like I said, intravenous opioids are your morphine, fentanyl, oxycodone, hydromorphone, okay? Then you've got subcutaneous opioids, so like morphine, subcut. Intranasal fentanyl, very good, excellent drug. And then you have ketamine. Okay, so apart from this, what else can we do? So you could do muscle relaxants. You could do neuropathic pain management, like the one we spoke about, the gabapentin, pregabalin. So if it's a nerve pain, we could do those. We could do nerve blocks or regional blocks. Yeah. So look, nerve blocks are excellent, especially when the pain is localized to an area. It's really good. So for example, if the pain is in a single digit or limb, just one area, or it's a dental pain, or if it's a sciatica, like we know it's localized in that area, right? So we could do like a regional block. They will have a good benefit as compared to giving somebody like Panadol every 4 hours, or giving them morphine, and then the next thing, you know, they go into respiratory depression and you have to take them to ICU. you? Like, so think about what kind of pain, and then how will you address it? Okay. So nerve blocks, very good, especially also if you're going to do a procedure, like you need to put on a cast, or they will need to go to theater, or it's like a trauma, or like whatever. So you can do nerve blocks. Okay. So these nerve blocks are usually done by senior doctors, and they can be done just with their expertise or using an ultrasound as well. Okay. All right. Then a little bit about opioids. So opioids can be given, like I said, orally. They can be given subcutaneously, intravenously, okay, intranasally, topically. So topically, they're patches which come. So topical patches are for people who are like chronic pain. We need to manage the pain. Like, for example, somebody who came with hip fracture. We fixed the fracture, but we anticipate that the pain will go on for a few more days until healing takes place. So instead of giving them IV or IM, we can put a patch, which is like, we know it's like a certain amount which is released in the system every hour. So they have a patch. Okay, it can come in a patch form. These are great drugs. You need to look at the side effects. So side effects, the worst is respiratory depression. This is the worst. Another thing you need to think about is the risk. So addiction is the risk in prescribing opioids. It is not a good choice for chronic pain. So keep that in mind. It's not a good choice for unknown pain. Like if you don't know where the pain is, you do not prescribe opioids. If it is like abdominal pain, you do not prescribe opioids. So you need to locate, you need to understand the pain. You need to understand what's happening, and then you can give it. It's always used short term, sparingly, and we avoid it where possible. We try to avoid it, because in Australia, another big problem that's happening in the hospitals is opioid dependency. People come in just to get opioids. It's a big, big problem. So we try to avoid it as much as possible. Okay. Ketamine. So next thing, ketamine. So what is ketamine? So it is an excellent source of analgesia. It's really good for procedural sedation. Okay. It's very good. Like if somebody, let's say, has pneumothorax, you need to put in a chest tube, or they have like pleural effusion, or they broke a bone, you need to like put on a cast, or like all these sort of, like traumas, you need to do the management. Ketamine is really good. Okay, so ketamine has a dose dependent curve. Depending on the dose we give is the effect that we have. So depending, like if you do like 0.1 to 0.2 mg, it gives an analgesic dose. This is, 0.1 to 0.2 mg per kilogram. This is an analgesic dose. Okay, this will give very good analgesia. If it's 0.3 to 0.5, it will cause like hallucinating. So you can say that people also use it for recreational purposes in Australia. So it's a street drug. So ketamine can be found with people who do drugs. Very common. So that's the dose for recreation. If you're thinking of sedating somebody, 0.4 to 0.8, this is like a partially dissociative dose. So they will partially, like, they will be with you, but they'll not be with you. Okay. Then 0.7 mg per kg is like a fully dissociative dose. They will not remember anything. Okay. So for children that we need to do like a procedural sedation, we use, like, for example, elbow dislocation, sutures. So we need them to be like knocked out, right? We cannot do sutures on somebody who's awake and they're a child. So we could do ketamine. That's a very good option. Okay, so in this, in children, it's I believe 1 mg per kg, and this is like a fully dissociative dose, so they'll be gone. Okay, you could also give ketamine intramuscularly. So for example, if a child has come and they are really unwell, it's like a trauma, you don't waste time to find an IV line. You could do intramuscularly so they can sleep and you can monitor them after that. And also like events where you can't like get IV access. So just do intramuscularly, solve the problem, okay? It's a good drug. The good thing is it does not cause any blood pressure depression or respiratory depression. It's a very good opioid sparing analgesic effect. Examples, for example, like places where we can use them, like for procedural sedation, trauma, severe like bowel obstruction, chest drains. So this is an excellent choice, okay? So keep this in the back pocket. So ketamine, right? Of course, like you will not do it as an HMO. It's always like done with the supervision of senior registrars, consultants. They have to be there, okay? Because once you sedate them, then what? You have to fix them, right? If it's like a procedure you're doing, there'll be a team involved. But it's good to know that this is a drug that we use. Got it? Okay, cool. So what else can we do? So we spoke about muscle relaxants, neuropathic pain, nerve blocks. Buscopan is a very good drug that I use a lot for spasms, like abdominal spasms. So yeah, you could do other things. And please do not forget your non-pharmacological methods. They're very important, and talk about them in AMC exams, okay? So how do you guys feel at the moment? Do you like what we've talked about? Are you happy?
Yes, yes.
Okay, good. So takeaway. So the goal of pain management in emergency or as a GP is not zero pain, okay? But making sure that you reach an acceptable level, you make your patient comfortable. That is the goal, okay? When choosing the route of delivery, oral is preferred unless the patient cannot tolerate oral medication. That's the rule, okay? And then consider a combination of non-opiates. So you could do like a combination of paracetamol and ibuprofen, which is a good start point, rather than starting with giving oxycodone. Okay, so always start with moderate things and then go into the severe things. And like I mentioned to you earlier, opiates have a real problem in this part of the world. We only give it if it's necessary, and we need to see what are the risks involved. So if it's somebody who's doing IV drugs, I would like be a bit hesitant to prescribe them. So because it causes dependency, okay? Make sure you treat pain before ordering your blood investigations. Do not leave your patient suffering until you get your results back. So fix the problem first, yeah? So in AMC, once you've ruled out your allergies, prescribe something. Say that I would like to prescribe blah, blah, blah. Samira is saying, Dr. Kindly, please explain a little bit about patient-controlled analgesia. Sure, okay. So make sure you treat pain before you move on in AMC, okay? Chronic pain. So we spoke about acute pain, a little bit about chronic pain. I'm not going to show you what chronic pain is. Why don't you guys give me some examples of chronic pain? What do you think can cause chronic pain?
Any joint problems? Rheumatoid arthritis, SLE?
Osteoarthritis. Mechanical injury to the back.
Okay.
Fractures. Or back.
Acute. But the post, like
yeah, like osteomyelitis and after that, sort of.
Okay. Okay. Cancer pain. Very good, Tasneem. Very good. Okay. So a little bit about chronic pain. So chronic pain is one of the most common reasons for seeing a doctor. Okay. Like usually they go to GP. Sometimes they come to ED. Well, not sometimes, quite a lot. So chronic pain, you could sort of classify it as myofascial, musculoskeletal, neuropathic, fibromyalgia, and chronic headache syndromes. So these can be like the main chronic causes of pain. Yeah. we're not going to go into them, but again, like chronic pain, similar approach. In Australia, there is a service called pain services. So somebody with chronic pain, like let's say cancer or fibromyalgia or some kind of sciatica, they will be seen by pain services. So if you have a chronic case, a chronic pain case, you can talk about pain services. So you could refer them when you talk about management, R. So reassure, refer. So John, I will refer you to the pain services where we can address your pain in a long-term solution. Got it? Pain services. So pain services have specialized nurses, doctors who are like pain experts. And usually they can put people on patches, which are like long-term. So buprenorphine, Suboxone. So these are like patches. You don't need to know them. AMC is not like asking you for these things, but these are options for pain for long-term, okay? And also like, how can they manage, like, so morphine as well, like, or opioids, like prescribing them for long term. So it will be done under pain services. It will never be done under ED or GP. Yeah, cool. Okay, so yeah, so that's something. Alrighty, so again, the rules about pain management. Oral is preferred. Analgesia should be given regularly, enough to maintain pain control. So you do not just prescribe and then disappear. You need to make sure that it's regular. So for example, somebody with renal colic, right? You give them, let's say, you give them ketorolac or morphine, and they're okay for the first hour, and then you disappear, and the pain will definitely come back. Like, it's a renal colic. There's, you know, like a problem which needs to be fixed. So you make sure that there's enough analgesia to keep going until the problem is solved. Make sense? It's not just a temporary thing. You need to make a plan. Okay. And choose the agents based on the intensity. Like we said, mild, moderate, severe. The dose should be adapted to the patient, and the agent that you're choosing should be adapted to the patient. And if you are discharging somebody, make sure you give clear instructions on how to take the medicine, when to take the medicine, what is the possible reaction to the medicine. Okay. So always give very clear instructions, and you can say that in your management as well, that this is what I will do, you know, blah, blah, blah. Okay, cool. All right, this was amazing. So let's practice some cases, what to give when. Okay, yay, let's have fun. Okay, so 9-month-old child crying in pain. What is this? Who wants to describe this? So first of all, let's see, what is this?
There is a spiral of fracture in the femur of right side.
Okay. Dr. Khalid, how would you go with this?
This is the femur fracture in baby, right-sided. So first of all, lie down the patient, ease the patient, and secondly, give some Panadol. 9-month-old, so Panadol, that is the better choice. If yep.
What else?
I think so. Need to be I don't know what further we should.
How much pain do you think this child will have?
Sorry?
How much pain do you think this child will be in?
It could be like 6 or 8.
Okay. Okay. So anyone else? Oh, good. Guys, where are the claps? I want to see some clapping. Yay, good. Thank you so much. Okay, so let's give somebody else an opportunity as well before I talk. Any other takes, guys? Any?
I would say he's like 9 or 10 out of 10, and I think you need direct, like the strongest painkiller you have, because you'll be in excruciating pain. You know, you'll be child will be crying non-stop. His mother will be shouting. So it's like we going directly to the codeine, you know, like morphine family, to control the pain for a while we call the specialist team, because it might need extra X-ray, you know, like to look on the lateral view to see if there is an anglement or some displacement of the two bones, bone fragments, because it might even need, you know, like intervention after that, fixation, or we go to the theater.
Excellent. So again.
Oh, thank you.
Yes. Good. Look, the first thing, there are a few things I'll talk about with this scenario. So this is a 9-month-old child crying in pain. This looks like a very nasty fracture. So at what age do you expect children to start walking?
So at least around 1 year?
Around 1 year, right? So this is a 9-month-old child. So they're definitely not walking, at least. That's what I'm thinking.
It's a non-accidental injury.
So how did they get this fracture? So in my head, the first alarm that rings is, OMG, something is not right. This is obviously, like from the fracture itself, the kid is 10 on 10 pain. It's excruciating pain. That fracture is bad. The second thing I can see is it's talk about the fracture. So we know it's the femur. So we need to talk about what kind of fracture. So it's a spiral mid-shaft right femoral fracture. Okay. Now, is it displaced or undisplaced? I would have to see the lateral view to say if it is displaced or undisplaced. Highly likely it is displaced. So this kid is in a lot of pain. Panadol, unfortunately, will not work. So I need to fix this problem quickly. So the first thing I could do is a quick intranasal fentanyl. Okay, that's a good option. We do in kiddies that come. So this is severe pain, guys. And I can tell the mom to be there or dad to be there. I need to quickly get somebody, like one of the senior people involved. The next best thing I could do is a nerve block. I can talk about a nerve block, because if we do a hip block, a femoral block, that will reduce the pain to quite an extent. Instead of, you know, repetitively giving a child opioids and creating a new problem, we can just do a nerve block locally, sort the problem. But intranasal fentanyl is a good approach to start with. Panadol will not work on this kid. Ibuprofen will not work. You need to fix the problem. Yeah, easy. Then, of course, the next thing I'm thinking of is non-accidental injury. So that's on top of my list, which is, again, a common thing that happens. Right? Then so this person is for further management. So we could also think about ketamine, because you'd have to put on like a cast or reduction or whatever surgery, depending on how bad it is. You can talk about other approaches to the pain. Another good approach to pain is diazepam, Valium. Okay, so you can prescribe some diazepam in a small dose that will relax the person a bit. Yeah, so that's another go. Cool. Let's show you the next photo. 39-year-old male, sudden onset, left flank pain, radiating into the groin. Let's see, what are your differentials? Come out of
Renal colic.
Renal colic, yeah.
Good. What else?
Ureteric colic, any UTI,
UTI, yeah.
trauma.
Dr.
Muscle
Martha?
spasm.
Could be any trauma.
Say that again. Sorry.
Could be any trauma, like accidental injury.
39-year-old. Yeah, they can have a fall.
Hold on. Like, yeah.
Yeah, why not? When you're thinking differential diagnosis, I want you to think like that. Look everywhere, okay? Like as much as you can. Don't have your blinders on. Look at the anatomy. So look at that area. So over there you have muscle, you have the hip, you have the kidney, you have intestines, the bone. So think about all the possibilities that could happen. And the more you can think with anatomy, the more differentials you will have. So in AMC, whenever you're stuck, think anatomy. And whenever you're more stuck and the brain is not working, then think about trauma, malignancy, and psych as a TMP, okay? Trauma, malignancy, and psych. So psychogenic, psychiatric conditions, TMP. Oh, sorry, TIMP. Trauma, infection, malignancy, psych. Okay? So this is like your resuscitation backup, TIMP. If you can't think of any differentials, go there, but don't go there in the beginning. In the beginning, you need to talk about the most likely things. Okay, cool. All right, so you're right. So we're thinking of renal colic here. What is our approach? So let's hear from Dr. Maisa. Hello.
Hi. Well, in this patient, I had to approach him the pain scale, ask him probably severe pain. I would go for opioids for him. Yeah. Depends. If I'm in the emergency department, yeah, probably IV morphine, for example.
Yeah.
Yeah.
Okay. So keep in mind that's correct. You're right. So it sounds like it's a renal colic. So for renal colic, we go with the like moderate to severe approach. So moderate to severe means, again, we are still considering the non-pharmacological things. So like quiet room, reassurance, giving them a position which is comfortable, then making sure we still give them regular, okay? So regular Panadol, regular Nurofen. On top of that, we give them IV or IM opioids, okay? So you need to have like a whole, like the whole package. You give regular every 4 hours, like 4 times a day Panadol, 3 times a day NSAIDs, and on top of that, you can do like 2 hourly opioids. Okay, so 2 hourly, let's say morphine, you can do on a drug chart, 2 hourly, or you could do ketorolac, fentanyl, so things like that you could do. Okay, but regular analgesia is very important, because this will be a pain that will go on for at least a whole day or 2 days. So we need a plan. Okay, very good. Excellent. So I'll just show you like a case that, like, just to give you an example. So let's say 27-year-old Gravida 4 para 2 female at 25 weeks gestation presents to the emergency department with right upper quadrant abdominal pain. Okay, right upper quadrant. The pain began yesterday and was initially a generalized discomfort that localized to the right upper quadrant. She has associated nausea without vomiting and has had minimal appetite for the last day. Her vital signs on arrival to the ED are temperature is 38.2, heart rate is 125 beats per minute, respiratory rate is 22, blood pressure is 110/70. Abdominal exam reveals localized right upper quadrant tenderness and voluntary guarding, but no peritonitis. So what are the red flags here? By the way, OB cases, like obstetrics cases in AMC are, there's a trauma case that comes like after a motor vehicle accident. There's another right upper quadrant case. Look, I don't want you to focus on recalls, but I want you to focus on the topic. Like what are the topics which are coming and how do you approach them? That will help you way more than memorizing the recall and, you know, making a difficult situation for yourself later. So yeah, let's get out of mute. Let's talk. First of all, what is wrong here? In the scenario, what is not correct in the vitals?
Temperature.
Okay, what else?
Blood pressure.
It's tachycardic.
Yeah.
Tachycardic and tachypneic. And she also, obvious tenderness and guarding is also there. So obviously she's been having, there is some major pathology going on there. Since she's pregnant as well.
Yeah, that's a red flag. Yeah, good, very good.
Yeah.
Yeah.
So considering all these things, you have to think of a lot of things. It could be something going on with her liver or her gallbladder, or it could, considering the anatomy, I would first think of, because she's pregnant, obviously I want to rule out abruption and then go into hepatic emergencies like HELP syndrome or something like that. So I would go in for more further investigation. But yeah, these are the things which would alarm me.
Okay. So the 2 minutes which you're reading, a good candidate will pick up the red flags. Okay. So the red flags are pregnancy, the temperature, tachycardia, right? The examination. So the things they give you, they indirectly mean the differentials. Okay. When they say, did you see the case of headache that Dr. Sami showed you? It said there's no CNS exam is normal, this fundoscopy is normal. Like, so basically what they're giving you is that the differentials, this differential is out of the way, this is out of the way. So when you do focused history, you're not wasting your time asking those questions. Got it? So be very careful, be selective at reading. So read cases and pick up what's there and what's not there. A good approach also, like to become familiar with reading cases, you could go with the Oxford handbook cases. I'll share the link. There's a Oxford series of OSCE cases. They have like big cases, and then just first read the case, pick up the key points that you think make sense and what are the red flags, and then try to write on a plain piece of paper the likely diagnosis and differential diagnosis, and then read the answer. I will share this information with you. If I don't, remind me. Okay. Okay, so this case. So first thing, a structured approach is very important, very, very important. Sorry, I didn't get the name of the doctor who spoke earlier. So she said, was it Dr. Kathy? Was that you?
Yeah.
So Dr. Kathy mentioned like ruling out abruptio. So again, like if we go in with like blinders like that, then we will miss all the other things which are there. Okay, so when we approach a case, we want to go like that. Okay, so the first thing we want is a structure. To do that, we need a structure. And more than we need to show somebody else, the examiner. We need to show the examiner that we have structure. So a structured approach is important for evaluation of a case. So for example, in this case, we have a pregnant female with acute abdominal pain, okay? So the approach should address systematically, excluding urgent and emergent etiologies. Okay, urgent etiologies are things like biliary colic, then appendicitis, pneumonia. So these are urgent. Emergent, so like emergencies, these are like the ones you said, right? Abruptio or intrauterine fetal death or distress. So these are emergencies. HELP syndrome. So these are emergencies. Does it make sense? So the approach will help you. When you have a good approach, you will be able to exclude urgent and emergent. Okay. So this begins obviously with taking a good history, making sure you understand the complaint. So SOCRATES, so follow SOCRATES, understand the current and the past history. So are they regular with the obstetrics checkups, their gravida 4. So I want to know, and the para 2. So I want to quickly know about the past history a little bit, like the past obstetrics history. Any medical, surgical history, family history. So quickly, like follow your structure. It's very, very important to inquire about recent trauma. Okay. As like there's a high chance of domestic abuse in pregnancy. So these are, you know, I'm not making it up. So there's a high incidence of domestic abuse, which increases with pregnancy. So ask about them. If there's any recent trauma, if there's any injury, how's everything at home, and do confidentiality. When you do that, the examiner would appreciate your approach, and they know what you're thinking. Because like given with the COVID times, like nowadays, like domestic violence, family violence is up there. It's really up there. So if you can show this in your exam, in your like in your structure, that you're thinking about that as well, like mental health and well-being, they'll be good. And keep in mind, the patient themselves will never say, I have been abused. You need to dig. You need to dig inside that area. Okay. It will not be volunteered by the patient. Okay. And I always like try to, whenever I see a pregnant person, I always say like, hey, Jenny, look, your health is important, and whatever we discuss is between us. I just want to know if everything's okay at home. Do you have enough support? How are you doing at home? Okay. And if there's something, they will tell me. If I don't do that a bit of confidentiality, they won't tell. Okay, anyhow. So asking the patient to describe the quality, like in their own words, will help you to differentiate if it's like a visceral or like a peritoneal symptom. So try to understand what kind of a pain it is, radiation or not. Again, if you have a good structure, if the pain is radiating or localized, it will give you more differentials. Physical examination, either with examiner or without examiner, will give you a lot of information on what's there and what's not there. Okay. So what are some of the non-obstetric causes of acute abdominal pain? What do you think? Like non-obstetric causes of acute abdominal pain in pregnancy?
Like you said earlier, it could be appendicitis. It could be like if according to the quadrant, but even otherwise, it could be hepatic. It could be biliary. It could be even lower lobe pneumonia can cause somewhat like an upper abdominal pain. It could be GI causes like just colicky pain because of gastroenteritis, or it could be infections, or it could be renal, and
yeah, very good.
Yeah.
Rule out gynecological causes too, like before if she was having any cyst in ovary or red degeneration of fibroid.
Yes.
So,
That's an excellent one. Yeah, good. That's again a non-obstetric cause. Lovely, love it. So yeah, so you've got like the common. So one thing, people, I want you to keep in mind, if you talk about differentials, the things you talk about which are very common will make you commonly right. Okay, the things which you talk about rare are rarely right. Okay, so everything that's common will mean that you're commonly, like you're very common and you're right. If you talk about like let's say aortic dissection, right, it's rare. If you talk about like ovarian cancer, it's rare, so you're rarely right. So be very careful. Talk about the common things, A, B, C, D, just talk about them. And anatomy will help you to give you the differentials. Okay, you can go quadrants, you could go organs, you could go layer by layer, like the skin, the muscle, the underlying organs, like the gut. Then you could go with like the bone, so the nerves, the blood vessels. So things like that can also give you differentials. So over here, I'm thinking of appendicitis. I'm thinking about biliary disease, like biliary colic, bowel obstruction. Then I'm thinking of peptic ulcer disease, GORD, reflux, perforated viscous. I'm thinking about stones like kidney stones, UTIs, pyelonephritis, cystitis, things like that, intra-abdominal hemorrhage, like trauma or things like that. So these are all non-obstetric causes of acute abdominal pain in pregnancy. And my only takeaway message for you is have structure. That's it. If you have structure, it will show. The person who's listening to you, they will see it, that you have structure. Okay. So that's about it. I hope you enjoyed today's session. And I hope it was fun for you. Sorry, I went half an hour over time. I just saw it already.
Sorry, doctor, I just had a question regarding the previous case that you mentioned. So in this kind of scenario, yes, we did the differential, but how would you approach the pain management in this case?
Yeah, good. So you could do the Panadol, Nurofen, right? You can go for these. So start with, first thing, non-pharmacological approach. Okay, so these are like making sure the mom's comfortable, making sure she's in a quiet space. Also keep in mind that she has other kids, other children, so also address that, because that anxiety would also like make her unsettled. So make sure there's a nurse who can help look after the other kids. Then in addition to that, so is she having, you go with the same like approach of SOCRATES. So try to identify like the whole like scale, the severity, and then go mild, moderate, severe. Same thing. So if it's mild, you go with the Panadol. If it's moderate, you go with Panadol and NSAID. Then if you feel it's a severe component, you could do opioids, IV. Yeah. So the main goal here is to address the pain and follow the mild, moderate, severe. You can give opioids in pregnancy. Yeah. So that's about it, really. And the approach of how you do it is very important. Do not forget to rule out allergies, because there are quite a lot of people who are anaphylactic to opioids. Yeah. So always, when you talk about giving pain relief, say that, examiner, I'd like to rule out allergies and offer analgesia to the patient. And don't say to the patient, say the name of the patient. So whatever the name is, Jenny, Samantha, Lucy. So it will show that, you know, you respect the person and you're talking about them. So
at this point, do you think it would be important we say the name of the medications to sound smart, or it's not necessary? Yeah, we just need to address with the medication and okay, yeah.
So the medications, the dose, they're asking you nowadays, I mean, everything will change nowadays. So the new cases will be different, okay? But they're asking you to fill the drug chart. Okay, so when you fill the drug chart, you need to know some common doses of Panadol, ibuprofen, what is the frequency. So go through that, know that, because even when you start working, these are common things you have to do. Yeah, so please go through those things. There are few medications which you need to definitely know the dose, like adrenaline, the heart, chest pain management drugs, you need to know the doses, anaphylaxis, then hypoglycemia. So we'll talk about this in another session. I'll take you over them. But basic things like Panadol, how much to give, it's usually 1 gram. So no dramas. And if it's a child, it's weight dependent. So 15 mg per kilogram, and then the weight, and then the dose, whatever it is. Yeah, easy. Cool. So you guys have a good day. Enjoy yourself. Do not take things too seriously. I hope it was a good learning outcome for you with Sammy and my lecture. And if you have questions, feel free to ask. And
yeah, I have one question that, like, starting with the format of history and patient, first we need to ask about the vital signs, like vitally stable, and patient is come with like acute abdomen with the pain, like severe pain. So ruling out the pain scale at the moment, and then allergies, we should offer any medication, like she's having a 10 by 10 pain. So do we ask the examiner to go for IV route at that time if she's not able to resist the oral medication?
You can, if you want to be one step ahead of others, you can talk about the route. And one more thing, if the patient is vomiting, sorry, I didn't add that, you need to talk about antiemetics. Okay. Ondansetron, metoclopramide. So also address that. So treat the symptoms before you go on to history. So if somebody is having acute abdominal pain and vomiting or nausea, say that I would like to rule out allergies and prescribe a suitable analgesia and an antiemetic agent.
All right. Okay. And then we will progress towards SORTSARA and other. First, we need to ask pain scale, offer analgesia, and then rest of the things we'll do, right?
Yes, that's right.
Thank you.
Yeah. So, yeah, that's it.
Thank you so much,
Doctor.
Yeah, no problem.
Can you repeat
some questions? Like, do you have any plan to start a separate course like medicine, pediatrics, or like that?
Yeah,
for
so
us?
there are stations where you need to see, now that the exam is online, highly unlikely that they'll make you fill a drug chart. I don't think they will, because you need to actually physically fill it. But you need to be aware of what the drug chart is, what it looks like, what are the sections, how I can take you over that another day. It's super easy. And yeah, I can take you over that. I was just seeing if I have a drug chart here. I don't. Otherwise, I would just show you now. Yeah, so there are different places where you write medications. If you can go through some videos, some documents, you'll see it. I believe I've done a lecture on medication chart long back. If you can look into the history, or maybe YouTube, you might find one of my lectures. Otherwise, I'm happy to do it. So most important thing is ruling out allergies in a medication chart. Okay, and making sure the medications like ibuprofen, Panadol, if you're doing morphine, these are in PRN, meaning as required. So then the patient is not suffering while you're not there. The nurse can administer the medications if they're written in PRN section. Okay, that's about it. Yeah.
Excuse me, I have a question. Early on, you have said regarding the pain, pinpoint the pain. So it should be with the one finger, or sometime when there is a diffuse pain, patient, they are saying like, for example, MI pain or ischemic heart disease, they are saying like, I have a pain in this area of the chest. So they can't able to pinpoint. So sometimes abdominal pain, that is not pinpoint pain. So in that case, we should say like pinpoint the pain. Like,
so the goal is first to understand the location. So with one finger, if they can point to the location, good. And then you ask, is it just there or is it around the area? Like, is it like, how diffuse is it? Yeah. So to understand like how far off does it go? And then once I've understood, okay, it involves like the whole chest, or it just involves that area, and I understood how wide that area is, then I want to ask, is there any other location? Because it could be they're having pain in the chest, but also pain in the arm, like it's, you know, in the arm as well. So you can ask, is there any other location? Does that answer your question?
yes, yes. Sometimes like the gesture of the hand or gesture of the patient, it says a lot. For example, if he is pinpointing the pain or she is pinpointing the pain, it could be the traumatic pain, or it's just chondritis. So it's a localized pain. So it's an external pain. And if somebody is just putting the hand on the chest and says, oh, I'm feeling tightness or pain or pressure, so it's more towards internal organs, and it's more understandable. So that's what I.
Yeah. So see, the reason why we do the Socrates approach is to basically understand if it's like a visceral pain, the character, the questions we ask like will help identify what type of pain it is like, and based on that we can go with the approach. Okay, so the location, of course, like it's very difficult to pinpoint costochondritis. That's like usually a diagnosis of exclusion. Like, so basically the goal here is to not miss the red flags, the key things which can be dangerous, like emergencies, right? And following like the one finger approach. So I've seen in Australia, like most of the doctors, the Aussie doctors, this is their approach. So they ask the patient, John, like with one finger, can you point to the location where it hurts? And then they'll ask like, is it just there? How is it just like there, or is it moving around that area? And if they say it's moving around that area, then whereabouts, can you show me? So then they could just like point. And also keep in mind, when a patient comes to hospital, they want to be helped. They're looking for help. So they themselves will guide you. They want to show you where it is. But if we don't have an approach, we cannot problem solve. The whole, like, Socrates is an approach to identify like the pain in the patient's body, then the description of it in their own words. Is it like dull, sharp, cramping? Is it stabbing? So if it's like a stabbing pain, is it pleuritic? So these words will give you the differentials, what to think. Is it radiating? Yeah. So when you have these kind of formula to think of problem solving, you will easily get to the bottom. And even if you do not solve the case, even if you do not come to the diagnosis, it's not the end. It's actually, people, in my experience, like teaching AMC for almost 2 years now, people who don't get the diagnosis are the ones that pass. Okay. The reason is the exam is testing you at the level of intern. Interns are not meant to diagnose. They're meant to differential diagnose. Okay. They're meant to think, oh, it could be A, it could be also B, C, D. I'm also thinking of this, but unlikely. I'm also thinking of that. It's possible. So we're never giving a diagnosis unless the task is specifically asking you for a diagnosis. Yeah. So keep that in mind. It's not about a diagnosis. It's about differential diagnosis and your approach. That's it.
Can I ask a question, Dr. Sharma?
Yeah.
Yeah. So there's a case in AMC in which the lady is diagnosed with pericarditis, and she's been taking multiple drugs. And in that case, they are very specific about it that you don't need to manage or diagnose her pericarditis. In that case, what AMC wants from us, do we have to talk about different pain options, or?
So what is the task asking you, like to relieve the pain?
Yes, it's the task that she's a diagnosed case of pericarditis, and she's been taking morphine, codeine, Panadol, NSAIDs, and she has got some other pains also, having some back pain, and the pain is not getting better. She's having chest pain even though she's taking these medicines, and now she's concerned about her pain, and the task is to take a history and counsel. And it is also written just below the task that you don't need to manage her pericarditis. I think people here might be aware of this case, which been coming very I think it came twice in 2019.
So if you send it to me, I'm very happy.
Oh, sure. Okay. Yeah.
Can do a lecture on it.
I think it was in this case that the patient had pericarditis about 2-3 months ago.
Yeah.
And now she's sort of getting addicted to the pain relief. That's what my perception was, not 100% sure.
Okay. So like I said, opioid dependency is a very big problem in Australia. It's a very big problem. Like on average in a week, I would see at least 5 people who are coming with drug seeking behavior. They're dependent. It's a real problem. Okay. So if you do not have an approach, you cannot find what to do. And you usually would go through the system on the computer, look at the past history, why they are coming again and again, what are the, previous presentations, and then you can find this information. So for that reason, we avoid opioids unless it's really, really necessary. In a case like pericarditis, pain is real. You need to manage it. So I would go with the step-ladder approach, make sure there's regular pain relief on board, every 4-hourly, like regular medications, which are your Panadol, NSAIDs, then the next level medications, which are opioids. These can be like the morphines, the oxycodones, the fentanyls, hydromorphones. So make sure you can go to the next step. But when you're choosing the next step of opioids, it's not all of them at once. It's one at a time. If one is not working, then you go to the next one. If you can show me the case, I'm happy to solve it.
I have sent you in the chat.
So I would,
oh, sorry. Yeah. Okay. Yes.
Would it be possible for you to send it on Facebook as well?
Oh, sure.
It was a middle-aged man with pericarditis on ibuprofen, but pain is not controlled. So ibuprofen will not control the pain. Let's first understand that. Pericarditis is painful. It will not be managed with ibuprofen. Okay. A past history of chronic back pain for which he is taking multiple medications like morphine, gabapentin, and 2 more. Okay. So take history. So when you take history, you obviously want to follow SOCRATES, like I said, follow the approach, counsel the patient regarding further pain control and management. So further pain control, if you remember, I spoke about pain services. So given this person has chronic pain issues, they need to be referred to pain services. Okay, so that's one of your plans. So you can divide this case in short-term and long-term management. Short-term management is fixing the pericarditis. So how can you fix the pericarditis in short term? The first thing is give them more appropriate analgesia. So you can say that I would like to follow this step ladder approach to analgesia and give the patient the next appropriate medication with an appropriate dose. In addition to that, I would also do investigations to rule out other causes. Could be his pericarditis is now a complication. Maybe there's a lot of fluid that has accumulated. You need to do an echo, organize that, organize x-rays. Maybe they're having pneumonia or pleural effusion. So show your whole approach. Fix the short term and long term. In the short term, also talk about involving the cardiology team. Say that I will call the cardiology registrar and have them review the patient. Okay, so depending on who you are, where you are, get help.
Excuse me, my name is Khalid. So again, regarding this case, maybe this is, they don't want to manage the pericarditis as note, but they want to talk about the addiction of the painkillers. So that's what they want to, the psychological and addictive history of these painkillers. So I think so this is the approach should be in this case. I don't think so they want to see the pericarditis to be treated by the painkillers.
So
I believe so.
another thing, no, I know that. You're right, Khalid. So I understand that pericarditis management is not asked, but you need to know that as well, because the task will change. So the reason why I do not talk about recalls much is because when you study recalls, let's say we like Saida studied this case, okay? The day of her exam, this case comes, but the task changes. But Saida only knows these 3 questions. What's gonna happen? Saida will be like, oh shit, like they didn't ask me this. What am I gonna do? So you made a grave for yourself if you focus only on the questions. So know the topic, understand the topic really well, and so as the day your exam comes, even if they ask you something random, you can answer it. You can, at least at the level of intern, you can manage it. Okay, very important. Now, like I said, ibuprofen is not appropriate for pericarditis. It's not appropriate. You need to talk about the next level medications. And whenever I prescribe opioids, or like I've seen Australian doctors do it, they talk about the risks involved of opioids. So in this case, you can talk about the potential risks, like what are the side effects. Okay, so you can say that, look, John, I understand you're having pain, and I can only imagine how bad it would be. Sorry about that, mate. What we're gonna do is we have a few options of escalating the pain relief management, and we can offer you some stronger medications, but they come with a risk involved. There's a risk of addiction, there's a risk of side effects, and talk about them, give them the risks. But don't worry, our goal is to only use it as a short-term solution until we can get you under the care of more specialized doctors and ultimately solve the issue. How does that sound?
Yeah.
So whenever we prescribe opioids, like I make a prescription, I tell the patient that only take this after you have taken your normal Panadol and Nurofen and it's not working, because there's a risk of addiction. You have to say that here in Australia. So if you've given a prescription, you educate your patient and tell them that there is a risk involved of addiction. For that reason, only please take it sparingly, and if it's really required. If it's not required, don't take it.
So Dr. Amrit, if a patient comes to us with addiction, would we, like with opioid addiction, how would we manage that?
So why did they come? What is the cause? Is it
for more painkiller, for more opioid?
So if
let's suppose this was a case of tolerance, like because of his previous pains, he was already taking these medicines a lot. So maybe this time these medicines are not having a good action on him and he's still having the pain. So what would be the next option for him?
So do you remember what I said in the very beginning of the lecture? So pain is, each person has their own response to pain, okay? We cannot be judgmental. We need to fix the problem. So the goal here is, if somebody has come with pain, let's say it's chest pain, and I know that they come every week to ED. I know that, like, you will know them. These people, when they come, you know them by face, by name, you know who they are, okay? When they come a new time, they're complaining of, let's say, chest pain, you still have to follow your approach. You still have to do everything. You still have to do ECG. You do have to do troponins. You need to fix their pain. You cannot be judgmental because they have like a behavior which is, you know, like, you know, their behavior, you know, they're dependent. You still have to fix it, because there's a possibility in medicine that they can have dependency, but they can also have a myocardial infarction. And if you do not, if you are like stuck on the fact that they are dependent on opioids and the person is actually having a heart attack, and the troponin comes positive and the ECG shows ST elevations, your career is over. Does it make sense? And you've not acted upon it, that's the end for a doctor. Like, you need to be non-judgmental. Like, you need to be super non-judgmental and fix the problem each time. But of course, this is why it's important to have a good problem solving skill. So have a approach, have structure, and you will be fine. Of course, like, if I know somebody is drug seeking, I will give them Panadol, Nurofen. While that is running, I will get my, you know, basic investigations. I might even give them the opioids, but at a low dose, very small dose, and get expedited results of whatever I want to do. Yeah, as compared to somebody who is new in the system, who's like in genuine like renal colic, or you can see their vitals are deteriorating. These things don't lie, by the way. The physiological findings do not lie. If somebody is in pain, you will see these.
Yeah, I'm just asking, like, if it comes as, okay, everything is fine now, and the reports and everything has come clear, and the patient is saying that it's the same pain, I just need some more medicine, or I need to increase it. Yeah. Would we manage it ourselves, or would we refer to some pain clinic or
pain services?
Okay.
Yeah, pain services. Your goal as a junior doctor or ED doctor is to rule out the red flags, the things which can kill the patient. As long as you've done that, you can relax. Okay, so back pain, like back pain, for example. I want to do a session on back pain, by the way. Back pain, for example, like if there's no neurology, then like, am I really worried? I'm not. Am I going to do a CT, MRI? I'm not. So if, as long as there's no signs which are indicating red flags, you do not need to do much. If you see red flags, you need to do much. Yeah. Will I not give them their regular like pain relief? I will. Yeah, I will. But I'm not going to give them like major drugs. Yeah. So have the mild, moderate, severe approach, have a good structure, you will be fine. I'll just touch base quickly on patient-controlled analgesia. Somebody asked this question. So basically, it's not very common. So I'm not even sure why you're asking that. It's not a station. At least it was not a case. So basically, it's a self-administered preset bolus. So it's the medication mixed with like normal saline or something, and it's connected to their pump, like to their IV line and a pump, and these are usually given for patients who have like, you anticipate that they are going to be in pain. So the patient-controlled analgesia is usually like a solution. It has its own infusion pump, and the medications are usually drugs like fentanyl, oxycodone, morphine, like the opioids, hydromorphone. And there's a set, on the pump, there's a set infusion rate. It's not like, oh, I'm feeling pain, let me just push the button and everything will come to me. No. There's a set, so we set the limit as to how quickly the infusion can run, and patients are usually sensible. You do not do PCA on people who are addicted. Okay, so it's usually done with pain services, and it's done as a plan. It's never done by an intern or HMO alone. It comes from a specialist. Like, let's say somebody has undergone surgery or they're palliative, it's part of a package, it's part of the plan, and there's a set preset dose, preset bolus dose, and the patient cannot mess with it. You cannot mess with it. Yeah, that's about it.
Yeah. Dr. Numeric, can you please share that pain services slide, if that's possible? Can you show that slide again? The pain services one? Yeah.
Pain services?
Yeah, because I just missed that.
No, I don't have
part of the session. Okay, that's
slide. That was just
oh.
extra I was talking about, like what pain services is.
Oh.
You naughty girl, you're late.
I just missed the middle part of the session because I wasn't able to turn on my video, so that's why. Yeah, I'm sorry about that.
No worries, no worries. Yeah, so that's about it, guys. I'll share the recording, don't worry. Yeah, so don't focus too much on things which are not common, that are common for AMC, like PCA, for example, is not very common for AMC, but it's important to know. So whoever asked the question, I appreciate it. It's good to know everything, a little bit about everything. So as if it comes in your exam, you can say a few words, sentences about it. You're not like Dodo standing there and you're like, oh, what do I do now? So it's good to know a little bit of everything. And whatever is common will be commonly right. Whatever is rare will be rarely right. Okay, that's it, guys. And yeah,
thank you.
I think we're good for now. If you have any questions, feel free to ask. Otherwise, we will see each other at another day, at another time. Farhana is asking, do you have any plan to start individual courses like medicine, pediatrics separately? Yeah, Farhana, so look, I have a full-time job and I purely teach out of passion. I love teaching, as you can see. And my goal of teaching is basically like, I went through really hard time when I was preparing for AMC. Financially, it was tough. Like Australia is not an easy place to start a career in medicine. Like cost of living is hard. Spending money for exam is really hard. Failing the exam and paying money again to sit the exam is really painful. So my main goal of doing these sessions is so as people don't have to suffer. And that's why I'm happy to do it. To do a course, I'm happy to do sessions on the days that I have like off. So for the next 3 months, I have a very good roster. I have weekends off. So I'm thinking to do I'm not sure. See, this is the thing. Like I can't do it if there are not many people. If there are enough people who want to do it, you can express your interest and I can think about it. Definitely.
Sorry, especially why I am asking, because medicine or pediatrics, no one can explain us like this way. Because I know like gynae or psyche, someone can teach, but medicine, how you approach and how you show that it's a very good that for us, like as a candidate. So that's why just asking.
Oh, thanks a lot. Yeah. So look, it's about passion. So when I teach, it's about more passion, and it's a problem I've solved myself, so I can teach you. And once you have learned it, like I'm not a business. Does it make sense? Like I'm like it's something that I know and I do it. I've done it. Like the exam, I sat it. I know what's the structure, so I can give it to you. Right? Does it make sense?
Yeah.
So that's why it comes naturally. And I think that's what makes it easier, because I've been through this journey, so I can teach it a bit easier. Sammy has been through this journey as well, so he can guide you guys on the approach, the structure based on AMC. Okay. As compared to like somebody who is an Aussie doctor, like they don't know what AMC is. They know a lot of knowledge. They're really good at what they do, but they don't understand AMC as such. Okay, so to do a course, I'm keen to do it as long as people are happy for the weekends. So in 3 months, it is something that can be done. Like, so the way I would recommend studying for AMC, especially medicine, since you've asked
Yes.
Farhana, basically is to focus on clusters. Okay, because there's too much information, otherwise you will go crazy. So think about the main clusters. So headache cluster, dizziness cluster, chest pain cluster, shortness of breath cluster. So this is how I teach. And when I focus on the clusters, I cover like key topics in that cluster. So for example, if we do chest pain, then we cover all the potential cases that come in chest pain. So MI, your pneumonias, pneumothoraxes, so traumatic, atraumatic, like that. So it has a more systematic approach as compared to like opening Murtag and studying one topic, another topic. When you do clusters, you are more systematic and you have more differentials. So my approach, even if you don't attend the sessions with me or you choose to go with self-study, whatever, please study clusters. Okay. Somebody is asking.
Everyone is asking about course.
Yeah, well, look, I'm happy to do the course. I like I said, I love teaching. It's something I do out of passion. So I'm super happy to do it.
Someone asking about the after hour course, like maybe 2 hours at night.
Could do a session. So I could do a weekend course for 3 months, 4 months, because I know my roster now for the next 3 months for sure. So I'm happy to do like the Saturday, Sunday, and on the weekdays I usually start at 7 in the morning and I finish at 5. So if I come home at 5, I need to eat and stuff, and then I'm free after 7. So back in the days when I was teaching more regularly, like before the lockdown, I used to teach also after I would come home. Like I would call the candidates and be like, hey, let's practice cases, because I have the time. So if I have the time, I'm happy to share more, do more. So that's not a problem.
How can I contact you? Like a email address or?
You can contact me on Facebook, on the group, or you can email me. Either one's fine.
Like what you send the link, that email, or?
Yeah, that email. Yeah, that you can email me on that. Physical examination, Umrah, the last session that I did, I spoke about physical examination and how we will use our words to do physical examination, okay? So I'm not sure if you attended last session, but I spoke about how it's super easy. It's not difficult. It's actually more easy than doing an examination. So you have to focus on anatomy. Like I'm like a bit depleted. My coffee's out, but so basically you're talking about telling your approach, like how will you do a physical examination, okay? Rather than like back in the days when you had to show it, it was more complicated because you have to keep in mind the patient. You have to be a bit careful on the spikes approach. Now it's more about you're telling them, this is what I'll do. And it's more easy, but you need to have good vocabulary. You need to practice a little bit more, know your words. So know the planes of your body. Like I'm looking at the anterior aspect, posterior aspect, midline, whatever, mid-clavicular. Make sure you have good directional anatomy. So you're talking about like superior, inferior, lateral, medial, proximal, distal, you know, like for example, like the x-ray I showed you with the kitty, what was it? Was it proximal? Was it distal? Was it angulated? So if you have good knowledge on these words, you will be able to go one step higher than other candidates. Okay, so now that this exam is online, please practice your fluency, your verbal fluency, very important. So if it's an examination of hip or knee or upper limb, so follow look, feel, move. So look, feel, move. So in movement, like you cannot move the patient, so talk about it. Like I would like to examine the movements by doing flexion, extension, abduction, adduction, and this will come once you practice. Okay, that's about it. So don't be scared of physical examination. It's something that can be done. And know the names of your special tests. Okay, I love how everyone's like mostly switched off their cameras. Okay, do you guys have any questions? Otherwise, I think we're good. So preparing for these sessions is fun. It takes time, by the way. It's hard work. But it would be good, you know, to see more doctors in the Australian system who are foreign. We need to support each other. So if you see somebody who's having a hard time, talk to them, be there for them, make friends, talk to other people, role play with other people. Yeah.
Yeah.
So share with other people. Like, you won't believe the amount of connections I've formed just teaching. It's incredible. Like last year, I'll tell you, last year, my mom was diagnosed with cancer, like breast cancer. I was in India and I was devastated. I didn't know what to do, but because I was teaching, I had so many doctors who were on the platform. So I just shared, like, look guys, this is what's happening in my life. And does anybody know an oncologist in India? You will not believe, within an hour, I was connected to 18 oncologists in India. Like people were so kind. And this is just to show you an example that, like, connecting with other people who are in the same journey, how it can open so many doors, like meeting people, talking to people, role playing. Let's say I am practicing with Farhana. Farhana got a job somewhere, and because she knows me, she will tell me, like, hey, there's a job in Queensland, why don't you apply? So please, like, make some friendships, make some connections. Don't be in your bubble. Okay, so use this platform to share and to practice as well. Okay, so that's all I can tell you. So for me, it's been excellent to meet other people. Like, you guys have helped me a lot, like the previous candidates. That's why, like, I do not hesitate teaching for free, because I take a lot of pleasure in doing that, because I know I'm solving a big problem for someone.
Yeah, that's a great help.
Yeah,
so,
like, money is important, but money is not everything. So if someone has a job interview and they are not prepared, I'm happy to talk to them for the job preparation, because I know if they get the job, I can change their life. Like, it will be such a big thing for me. Like, if somebody starts working, that would be the best thing I could do. Like, earning $100, it's nothing. Like, but imagine somebody being able to get employment to work as a doctor. That would be amazing, because somebody helped me. So
that is really very kind of you, Dr. Amrit. It's really very kind of you.
You guys can pay it forward. Like, you will also be in my situation one day, and when you do, help other people. Yeah, that's it. So yeah, go help other people. So Kathy, yeah, finding a job. Like last session that I did, I talked about job and stuff, like how to get jobs. So you guys, having passed already the AMC part 1, you're eligible for jobs. Apply for them.
I've been applying for so long. I don't even get an interview call. It's really, really, discouraging, because I don't know what's wrong, whether it's my CV or what they really require. What extra do I need to show? And as time goes, my recency of practice is just like going behind and behind. So that's really worrying.
Yeah. So see, you need to show recency of practice. You can do that with CPD points, but only the CPD points that are accredited. So keep in mind, there are a lot of these funny courses out there which are not RACGP accredited. They will say that you get these many CPD points, these many hours, but the reality of that is there's no accreditation behind it. So there are a lot of free online CPD points you can get. So last session, I shared some of those free ones. I can share it again. Remind me, I will share it. So do these courses, show that you are a learner. The reason why people get jobs is because they show that they are in the business of learning, in continuous education. Okay, now things happen, life happens, you're in a situation where you're not able to work in your field. People understand that, but what are you doing to cover that gap? Are you doing like a course? Are you preparing? Are you doing observership? Are you attending a GP clinic? So I told the class last time that when I moved here, like I'm an obstetrician back in my country, in Uganda. I'm from Africa, by the way. So moving here, I came from a very well-paying job to no job, like nothing, literally nothing. And to sustain yourself in Australia, you need money. And you'll see a lot of doctors, they do odd jobs to pay the bills because they have kids, they have families. So they live in like drive a taxi. Like I used to work in retail. I used to stand all day long and sell handbags. Okay, I did that because it was paying the bills. But the minute I understood that if I pass this exam, I can make $100,000 every year. The minute I understood that, what did I do? I invested in preparing for the exam. So I invested my time, my energy. I used to sit and study for almost, like, you will not believe, for almost 12 to 14 hours every day. Like my husband did not see me. He was very, very supportive, but I did not talk to him. We were like roommates. He would come at home and we would just like be like, hi, okay, start studying, eat quickly and then start studying. Like we would not talk to each other because for me, the focus was on the long-term plan, not the short-term enjoyment. People were having parties, they were having birthdays, they were going on holiday, but I chose not to because I thought if I can dedicate 3 months full time and get this out of my way, I will have a good future ahead. But if I have fun now, I will not have a good life. Okay, so you need to decide what is important. Is short-term happiness important or long-term happiness important? Very important. And the day you do that, you will succeed. Okay, you will pass any exam in life. So at that time, it was hard. So why do I do free sessions? Because I know the pain. I know what it feels like to sit the exam and pay the money. And I failed my first exam, by the way, the clinical. The written one, I passed with a very high score. The clinical one, I was super confident and I thought, easy, like I'll easily do it. But I failed it. And then I understood the reason why I failed it was because the approach to the exam was from people who have not worked in Australia. Okay, so I did a bridging course, but the people who were teaching the bridging course mostly were people who have not worked in Australian hospitals. They've passed the exam, but they've not worked. They do not understand allied health services, the approach, the lingo, like how do these people talk? And what did I do once I understood? Initially, like when I failed, I blamed AMC. I was like, oh, AMC this, that, blah, 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 blah. But then once I went through my feedback, I understood that the problem is me. I did not do the red flags. I did not do this. And I am lacking somewhere. Okay. So I need to bring my knowledge from a specialist level to an intern level. That's the first thing I had to do. So I had to talk like I'm a freshly graduate intern. Okay. And then I went and started knocking on doors. I started talking to GPs in my neighborhood. I told them that this is who I am. I'm looking for Australian experience. If you don't mind, can I do an observership? Can I just like do something? And I don't want to get paid. I don't want any money. So Kathy, this is my advice to you. Go knock on doors. Go talk to people who are in your neighborhood. Introduce yourself. If you are comfortable in your house, you are not going to be successful in the long term. Okay, let me just make it very like sharp to your face. If you're comfortable, you're not going to succeed in the long term. If you're uncomfortable right now, you're growing. You're creating an environment where you're growing and you will create a good future for yourself. So I was comfortable at home. I was comfortable studying on my own. but I realized I need to be uncomfortable now. So I went, knocked on doors. I said, look, hey, my name's Amrit. Like, this is my background. I have to do the exam. And you will not believe, like 2 GP clinics near my house. They're like, yeah, sure. You know, happy, like, come and see what we do. So I used to just go there, and the senior doctor, like the head of the clinic, asked the patient first, like, are you okay if, you know, Amrit, one of the doctors is happy to observe? And mostly people say, yeah, sure, they don't care. And I saw how he talked, how he spoke, how he did physical examination, and that made me pass the exam. So what I'm teaching you is actually the approach that Aussies take when they deal with a patient, when they work, as compared to, you know, what we do in our countries. AMC wants to see if you can work in the Australian system with the language, with the approach, with safety, and the knowledge. So when I did this, I knew, now I know enough, I can pass the exam. So please, if you don't have a job, get some experience from GP clinics nearby. And usually these people are helpful. They know. Most GP practices, like there's some foreign doctors working there, talk to them, introduce yourself, say your problem to them, share your problem, okay? So maybe Farhana is living in the next suburb, okay? But I don't know Farhana. But if I know Farhana, I know her problem, I can invite her to my hospital. I can invite her to be with me, let her watch what I'm doing, okay? But if I don't know her problem, how can I solve it? So please become uncomfortable. Go look for help. People are kind out there. They will help you. Okay.
And one more last question. What about this BLS course and, you know, ALS course? Do you have anything which you would recommend to take in Australia?
I did both for free at the hospital. Once you get a job, they will do it for free for you. Like, you don't have to pay $1,000. Okay. BLS is a good one to do, at least the bare minimum. You can do BLS to show that you have it, but it's provided for free at work. So yeah. So I didn't want to, my brother's like, don't do it. So I didn't do it. Yeah. Yeah.
Doctor, I have another
Thanks
question.
a lot.
I missed your last session half. So do you have any recording for this, your last session? Like
Yes,
you did.
if you cook for me like a good meal, sure, you can have it.
Yeah. Obviously.
I'm kidding. Yeah, don't. We'll sort you out. Okay. All right, everyone. So I think that's it. If you have questions, feel free to ask. And if you, yeah, like.
How can I get your last video? How can I get your? Oh, okay. Thank you so much.
I will post it on the Facebook group.
Okay. Okay.
Yeah.
Thank you so much.
Yeah, not a problem. I hope everyone's enjoyed the session as much as I've enjoyed it.
Yeah.
Yeah, obviously. We took your more than 1 hour again.
Yeah, that's
almost 20.
Thanks a lot, Dr. Amrit, really, for taking time out like this. It's really, really generous of you. Thanks a lot.
No worries, Kathy. So become uncomfortable, Kathy. Go look for answers. Don't sit at home and blame the world. Like, you have an option. You have an option. You can stay there, but you will not progress. Or you need to do something and progress. So I see it like drowning, you know, when you're drowned, like, I don't know if you've ever been in water and tried swimming, but when you're swimming in water, if you do not move your body, you will drown. And when a person is drowning, they move everything. They try to come out, right? So this situation right now for you guys is like drowning. You need to move yourself, like reach for help, get more knowledge, connect with people, like move yourself, become uncomfortable, and you will come out of it. I promise you will come out of it. But if you're comfortable, you're not going to come out of anything.
Thank you. Thank you so much.
You're comfortable, remind yourself, this is bad. This is bad. Like, if you're comfortable, it's bad.
Yeah, that's true. Thanks a lot.
No worries, no worries. But it's just a matter of time. Soon you will be also working. You will be on the other side. So it's just a matter of time. I promise you, you'll be there. Yeah.
Thank you.
Okay, see you. Bye.
Bye.